Okay, so we're going to discuss a few cases, and we're going to have we have an outstanding panel of clinicians who are going to review cases that they have not seen or heard before. And this is a real live scenario of how very experienced clinicians would evaluate and would think about a case in terms of the diagnosis and the approach to therapy of these patients. So we're going to have John Williams, who is one of our second-year fellows, start first-year fellows. First-year fellows. And he's going to present a few cases, and we'll call on our expert panel. Actually, let me just go around and introduce all of them. I'm going to just pass the mic around to each one, so if you can just give us your name, your title, where you're from. Pass around.
All right. Alan Cooper, I guess my title is Professor and Chief of Pulmonary at the VA, and I'm from Chicago originally.
Jerry Kreiner, I'm Professor and Chair of Medicine, Temple University in Philadelphia.
Vina Anthony, Professor of Medicine, UAB.
Jim Johnson, Professor of Medicine, UAB. I'm the Clinical Director of our division.
Rob Garver, Adjunct Professor, Andalusia, Alabama.
So as you can tell, there is a little bit of gray hair among this group, which means that they have a lot of experience. And I think it's that experience that allows them to be able to look at patients. The one disadvantage that these clinicians have is that they don't actually see the patient, they don't examine the patient. They're going to have to rely on John's description, and hopefully it'll give them some insights in addition to all of the clinical vignettes. So John, take it away.
Hey, I'm John Williams, one of the first-year fellows. I also have some gray hair after being asked to do all this, so, but I dyed it beforehand. So I should have called this Stump the Chimps. I didn't mean to imply that these monkey pictures I just thought were funny, but yeah, I'm going to try to see if I can't put together something a little interesting for you guys as the last portion of this. So I think it'd be appropriate that if the expert panel here doesn't know the answer to phone a friend or ask the audience, whatever the case may be, maybe we can have some informal polls about what's going on. But I hope these are interesting. I thought a couple of these are patients that I saw personally, and then the third case is one that was given to me by my co-fellow Angel Brown, who I guess had to leave. So I'll start with case number one. I called this one Deeper and Deeper because there's many layers. I would say that some of these patients, one of them in particular, has been at our facility, our university hospital, for probably 3 months. So Dr. Johnson on service about 11 out of 12 months out of the year, I think, is my impression. And so he's probably seen this patient in 4 or 5 different units. And so if you guys know who I'm talking about, try to keep it.
Jim's excluded from the discussion.
Keep it. No, he may or may not know this patient, but like I said, she's been around a while, so some of y'all probably have at least heard of her. But she's a 31-year-old lady who has end-stage renal disease, secondary to lupus. She had a deceased donor kidney transplant in 2003, and prior to presentation, her baseline creatinine was 1.4 to 1.6. Her immunosuppression was Imuran, tacrolimus, and prednisone. Also, unfortunately, has antiphospholipid syndrome, had prior thromboses of bilateral subclavian veins, and is on chronic anticoagulation with warfarin. She started to have dry cough, dyspnea, fever, chills in the month of October. So she also reported that she was having some diarrhea, went to another facility, and was treated for, the notes just documented she was treated for pneumonia. I'm not sure exactly how they treated her, with what agents, and then sent her home, and ended up, when she went home, she was still requiring 2 liters of oxygen. 2 weeks after her initial hospitalization at the other facility, she presented to the hospital again, persistent cough and diarrhea at that time, reportedly was hypoxic on arrival, improved with supplemental oxygen, also had fever and hypotension at that time, empirically treated with Zyvox, Zosyn, and azithromycin, and then was transferred to UAB several days later due to some kind of uncertainty about what was wrong with her, and they were uncomfortable dealing with this immunosuppressed patient with a kind of an unknown process. So I just wanted to see, was there any thoughts, initial thoughts from the panel regarding the patient? Maybe just a little thought process about what could be going on.
Actually, why don't we have Dr. Kreiner, Jerry, if you just come up and
also
give us
use this.
your...
For overhead. That's an overhead.
Oh, is that an overhead? Oh, good, that way we don't
You
have
got an overhead one?
Yeah.
Here, you do this and I'll wear this one.
Oh, okay, good idea.
It's easier.
So I'm glad I'm not on service. But I just briefly hearing about the case, the things that I think are most important is that the patient has a prior history of lupus. They ended up having a double kidney transplant. They're immune suppressed, and they present with cough and diarrhea, and the syndrome's been progressive. The antiphospholipid antibody syndrome is another kind of red herring into this that could be always the specter of further thrombosis related to that disturbance. But the things I would put on my short list from just hearing from this, is it related to lupus? Is it related to an opportunistic infection because of the immune suppressed state with pneumonia and diarrhea? Do you think it's CMV, all those patients a little bit further out from being immune suppressed? And I guess the third thing is, don't forget the things that happen with patients with pneumonia and diarrhea who aren't immune suppressed. So could this be Legionnaire's disease?
Okay. And that, I think that, can y'all hear me with this?
Yeah.
We good? Yeah. So that was our thinking as well. I think the admission, when she was admitted, the physical exam is as follows. She did not have fever, a little hypertensive, still requiring supplemental oxygen, saturated 97%. She has a really pronounced moon face, normal mental status, no lymph nodes. There was documented fine crackles in her left lung base, no murmurs. Her abdominal exam was benign, no skin rash. Any other exam that you got?
So she's afebrile.
And this is a few days after being at the other facility and on broad antibiotics.
So I don't know what benign abdominal exam means. Do you have she have any loose stool or
Just
rebound?
meaning soft, non-tender, with no abnormal findings.
How about mental status?
It was normal.
Okay.
She was completely intact. Neuro as well as mental status was normal.
Just trying to think what else I could be missing.
So as a student, I was taught that
How
every
about
patient gets a
anything-
rectal exam. So nobody asked for a rectal exam, but I would definitely. And somebody did do a rectal exam on her, and it was normal. There was no blood or any abnormal findings. So these are some of her labs. Her creatinine actually was slightly lower than her baseline. She did have a white count of only 5 with 90% neutrophils. Hemoglobin platelets are there. C3 and C4 were both documented to be low. LDH was elevated. Other LFTs were all normal, meaning her bilirubin, AST, ALT. Her CMV antigen was positive, serum antigen, and her serum CMV PCR showed 668 copies per mil, and she was also found to be C. diff positive.
So the things I would pick up from that are the CMV positive, the PCR being slightly up above 500 copies and C. diff positive. The things I would pick up on is the CMV PCR is above 500 copies and the patient's C. diff positive. I don't know what the C3 and C4 being low, and the LDH is a little bit up, but not that up.
Okay. And then this was her initial chest X-ray when she came to our facility.
So to me, it looks like she has some diffuse increase in reticular infiltrate, more left-sided than right. Maybe some nodularity into that, but I might be overreading that a little bit.
Right. And that was how it was read, as a left greater than right, kind of interstitial abnormality. And so she was sent for bronchoscopy shortly after arrival due to all the cough, fever, uncertainty about her diagnosis. Samples were sent for the appropriate micro cytology as well as pathology, and she was continued on broad spectrum antimicrobials. They added oral vancomycin for her C. diff and also added ganciclovir, IV ganciclovir. She clinically improved. Her oxygen was weaned, and she had no further fever. So she was discharged a week later, and bronch cultures were negative at the time the patient was discharged. So, was this a community-acquired pneumonia that was probably overtreated with Zosyn and Zyvox, or was it something else? So that was kind of where this case, where everybody thought this case would end, and she was discharged and was stable. She was however, seen in transplant clinic a week later again, worsening cough, worsening dyspnea, and any ideas about what her bronch culture might have been growing?
Fungal form.
Fungal? Any other guesses? Dr. Anthony, you should be saying something right here. What's your...
PB.
Exactly. Yeah, MAI. So her blood bronch cultures grew MAI, and she was started by she was seen in, we have a transplant ID clinic, a transplant infectious disease clinic, and they started her on therapy for MAI. She also brought her CT scan from the other hospital, which she had been admitted prior. She managed to get a copy of that CT scan, probably at gunpoint. I've heard they're pretty hard to get, but she brought that with her, and I put some representative sections of that. Any thoughts about the CT?
It's pretty diffuse ground glass with involvement of all lobes except the apical, I guess the apical of the left upper lobe, and some consolidative atelectasis at both bases.
So at that point in time, they reviewed the CT scan, and they, she was in the clinic, and so somebody happened to look back and review the pathology from her bronchoscopy, and that showed, any guesses based on the CT scan? Thoughts? Does this help?
Looks like, is it CMV?
She had PAP. So
PAP.
this lady had PAP. She it's unclear if she had an initial infectious insult. The thing was maybe the MAI was the cause of the PAP. But at that point in time, she, based on the pathology and her bronch results as well as the bronch pathology, she had MAI thought to be, or PAP thought to be secondary to MAI infection. She was seen in the pulmonary clinic a week or two later, and clinically stable, deemed to be not a candidate for lung lavage at that time due to, she was, I think, off oxygen totally at that time, and really was doing basically back at her baseline. However, the story doesn't end there. 6 days later, she came back to RED. She came to RED this time, not to the other hospital, with hypoxemic respiratory failure requiring high levels of oxygen to maintain her O2 sats, acute on chronic anemia, and acute kidney injury. This is her X-ray from her, again, when she came to the ER that day with hypoxic respiratory failure. Any make a comment on that?
She's up to like 7 or 8 diagnoses now.
Right. Oh no, it's not over.
It's not over.
She gets more.
I don't know, resolving PAP, MAI, CMV, I guess we're up to 3 now. Hate to give her another one.
There's her CT, and I don't know if you could, by memory, compare it to the prior one, but it was felt to be worse. She had some,
Right.
more consolidation and infiltrates on the left as well as on the right side. And so again, she was readmitted, treated again. The thinking was, well, maybe she had picked up a nosocomial organism, some kind of drug-resistant gram-negative while she was in the hospital, or something else. So she was treated with vancomycin. They continued her therapy for MAI, and they also continued valganciclovir. She had been on ganciclovir in the hospital, sent home on valganciclovir. She was intubated a few days after her presentation this time for worsening hypoxemia, and thoracic surgery was consulted, and they did a right-sided high-volume BAL, thinking that maybe her respiratory failure was at least in part due to PAP.
Were her antibodies checked at any time for GMF antibodies?
No, not that I can find.
Okay.
I reviewed her chart she has a long chart.
Yeah.
And I went through it as best I could last night, and
Jerry,
didn't find
that's
that.
a very good point that you bring up, because you've got, can you hear me? Can you hear me okay? So you've got a patient who's immunosuppressed. You've got a CT scan that clearly shows ground glass, some bronchiectasis, a diffuse pattern. You always have to think about infections in these patients. Now, I'd like to ask a comment, rather than infections at the top of the list before you think about lupus pneumonitis, for example, right? Now, how common MAI is in this scenario, I'm not sure. So Let me just ask, any of the other faculty members think, the panel think that this, how unusual this is, MAI in this setting? Secondly, is the PAP primary due to an antibody to GM-CSF, or is it secondary to infection? So if you want to comment on this.
Well, I think Vena can comment, but I think atypicals are a recognized infection that's increasing incidence in PAP. So that's how I would put it together.
So you think the PAP is secondary to the MAI?
No, I think the MAI is secondary to the PAP.
You think the MAI is secondary to the PAP? Anybody else wants to weigh in on that idea? Jerry?
I think that's a plausible diagnosis. I think that the pattern that she's exhibiting with the severe waxing and waning is more consistent with PAP than it is with an infection driving it. Any thought about getting a better piece of tissue, a bigger piece of tissue with a VATS biopsy at all?
Yeah, that was mentioned. So thoracic surgery was consulted at this time, and the question was, would she benefit? Would we get further information from a wedge biopsy or a VAT? And they decided, they kind of deferred on that point and said, well, we'll do kind of a therapeutic procedure with a high volume BAL of the right lung first, which they did, and this is a post X-ray. You can see she's still intubated, but here, this is probably 3 days post that procedure, and because of the fact that she remained intubated, they felt, well, the lavage was not therapeutic to the point where we would consider doing the left side when this X-ray was taken. However, she was unable to be weaned from the ventilator, so after some discussion, several days later, she underwent a left-sided large volume lavage, also for PAP by the thoracic surgeons. And this is her X-ray after bilateral. And again, she's remained intubated, but there was felt to be some improvement in her, at least in her X-ray. And I think at this point, her oxygen requirements for a little while got better. So despite the chest X-ray improvement, she did remain ventilator dependent. It's probably a week after the second lavage procedure, she again started having fever. Also around this time, kind of to the surprise of everybody, she developed a spontaneous wound in her right side and her flank. That was no trauma, there was no bed sore there was nothing there prior. She just kind of developed almost like an ulcer, is how it was described to me, and that started to drain large amounts of serous fluid. They weren't sure if that was ascites or what was draining out of this thing. They actually had to put a bag over it to just catch the amount of drainage because it was so copious that it would soak through dressings, and they couldn't keep a dressing on it. And around this time, because of the fact that she had new fever and they still couldn't wean her from the ventilator, they felt like maybe another CT chest would be appropriate just to see if there was anything else going on. So I have some.
So she has 2 cavitary lesions in the right upper lobe and dense consolidation at the left lower lobe.
So this was unexpected, I guess, to see the cavitary disease in this patient. That she had, MAI at first, then she had PAP, was treated appropriately for both of those, and now has cavitary lesions. So ID was consulted, and they had, of course, a long differential that all of the smart pulmonologists had already thought about. But I'll go ahead and just talk about what they mentioned. They mentioned nocardia, rhodococcus, mycobacterial infection, fungal, and then one thing, I don't think I put it up here, blasto was mentioned because she had skin lesions, she had lung lesions. So they felt like these were all possibilities, included, and also immune reconstitution inflammatory syndrome in light of her decreased immunosuppression that they had decreased a few days prior, or a few weeks prior, due to her ongoing fever. So she was treated, really continued on treatment for MAI, also treated with imipenem, amikacin, but however continued to have fever. And a few days after the CT scan that I showed, she had a seizure, so she was loaded with Keppra, and an MRI brain was done. Any guesses on why she had a seizure?
One of those things are in her head.
Because there's something wrong with her brain. Right? The other thought was the imipenem. That's with her renal function being tenuous and everything else, imipenem was mentioned as a possible cause of seizures as well. So she underwent an MRI brain, And I just put a couple of sections in here just so to give you kind of a, there was probably 7 or 8 of these scattered throughout the brain, but these are kind of 2 very prominent ones, or very remarkable ones that we're seeing on this MRI brain. So ID was reconsulted. ID has been reconsulted on this patient, I think 4 or maybe 5 times. So they know her well. And she was started on voriconazole and Abelset empirically due to concern for possibly an invasive fungal infection. Also seen by the allergy service for sulfa desensitization. No cardio at this point was one of their major diagnoses they were considering due to brain lesions, lung lesions, cavitary lung lesions, and also skin lesions. She remained ventilator dependent, but after being started on all of these medications and Bactrim, she was desensitized to Bactrim and started on Bactrim. She had a prior Bactrim allergy. She did no longer have fever, but remained ventilator dependent. And because the team was kind of frustrated at this point and wasn't sure what was going on, and she had some worsening hypoxemia, they did another bronch just to see, they did a BAL to see if the fluid was clear, if she had more cloudy fluid indicating maybe the PAP was there. And the BAL fluid was found to be clear. So really she kind of trucked along, no fever, but still ventilator dependent throughout this time. And then several days the microlab called to say that her BAL fluid was growing, something that kind of put it all together for us. It wasn't mentioned in the prior slides. Any guesses?
Whoa.
No, I don't know.
Blasto that was a thought. Actino was something else we thought of. She had a dermatiaceous mold that was in her bronch. It was Ochroconus. Ochroconus gallopavum was what we diagnosed with. She was trached and was continued on therapy with both voriconazole and Abelset, and actually improved clinically it took several more weeks actually. She's had multiple complications since all of this, but is finally now in our step-down unit on trach collar with not too much supplemental oxygen. I think she's on 40%, and ID is recommending lifelong therapy with voriconazole. So our ID guys, I will say to their credit, they called this about 2 weeks before the BAL culture came back, a week and a half before the BAL culture came back. They're familiar with this organism, but apparently not common at all, but is seen in organ transplant patients. And can cause cavitary lung lesions, can cause brain lesions, and also can cause the skin lesions that we're seeing, that spontaneously draining wound. So.
Okay, so thanks, John, for a very interesting case. And Dr. Kreiner, thank you for discussing that. Do you have any final, I know you have to run off to catch a flight,
Right.
but any final words of pearls of wisdom in terms of how you would have approached this case?
I would have got that smart ID guy the first day, but other than that, I think it just complicated case like this, getting tissue, and I think that probably all the infections in the PAP, there's a lot of red herrings and turns with it, that something was driving this from the beginning, and the rare organism rarely will have protein manifestations that will result in putting it all together. So can you tie PAP and everything else into this then? Do you have any associations with that, or it's so
Not
rare?
that I can find. Yeah, Ochroconus, it's very uncommon. There's really just case reports, mostly by the guys at UAB, actually. They've written most of the case reports, but no, I can't find an association between that and the PAP. MAI and PAP, she probably had more than one thing, honestly, but I thought the final, she's better now after being treated for Ochroconus, and that's the only thing she really wasn't treated for a long time prior. So I think that at least, as you said, it may have tied it all together in the end.
It's a great case. I hope they get more difficult. Ellen, you're next.
Thanks again. Thank you.
Thanks, Jerry. Thanks for coming.
Okay, so John, you are moving into the second case, or do you have anything more on this case?
No,
You can't have
that
any-
was it. I have
Okay, great.
another one.
So why don't we move to the next case, and do you want to have one, why don't you just move on? Let's get to the introduction of the second case.
Okay. Okay. So this is a patient. I saw this patient as a resident, so I don't have any actual X-rays or anything on this patient, but it was very interesting and again a very kind of a prolonged trip to her diagnosis. And she had I think she had several diagnoses that were interesting. And this, I called it back to the basics for two reasons. One, because I'm going to take you guys back to a little bit of a trip through internal medicine, which some of you probably have tried to forget a lot about, and also just the basics, because as you'll see later, she had a problem with her base. So 25-year-old white female who presented to the ED complaining of fatigue, irritability, overall lack of energy for several months, a lot of nonspecific complaints, but definitely fatigue and lack of energy. She had put on weight and complained of constipation, but had really not been eating at all. And then over a kind of a more acute time course, she developed a rash that she said was a sudden onset rash on her legs and back. It developed 3 days prior to presentation, and she also had fever and chills during that time. So, just wondering if anybody had any thoughts about these. And I'm not saying that these are the same diagnosis.
So Mark, any thoughts? 25-year-old presenting with somewhat nonspecific symptoms. This is a fairly common scenario, I guess, in our current world, but now you got a rash on her legs 3 days prior to presentation and had a fever prior to that at about the same time.
Am I supposed to come up there or no?
Might
Oh.
be easier.
First of all, I'm not board certified in internal medicine anymore. So I opted out of that opportunity to renew it, so not being qualified to address it, yeah. So far, this looks like primary care failure. But I guess the key issue would be, like as you highlighted, is the second worsening of whatever is going on in the first bullet, or are these two independent events? And we probably don't have enough information to answer that. The first thing, I guess, to me looks fairly nonspecific, although I would worry about hypothyroidism, I suppose. Although not all that fits with that either. You know, American Family Care or something probably would be my next step.
So does this help you at all? This is some things that she had on physical exam when we examined.
So I guess she's got eyebrow issues, which something to do with your thyroid. I can't remember if it's high or low, but that does that. And then skin lesions that look pretty impressive. I mean, I guess you would worry about.
And these were on her back, arms, legs.
Yeah.
This is just a representative.
So then think of things that we see in pulmonary. I would worry about fungal infections. I don't know why she would have that, but blastomycosis, I suppose, could affect an immunocompetent person. Tying those together, I don't know.
So this was Queen Anne's sign. It's, as you mentioned, a sign of thyroid dysfunction, hypothyroidism, usually pretty profound hypothyroidism. So this is her pathology on a skin biopsy, and I know there's probably not a lot of dermatopathologists here. I think they have the conference down the hall, but there's dermal edema, and these are all neutrophils, and she had a fever. With that, anybody put that together? I thought I heard some S's out there.
Yeah, sweet syndrome.
Sweet syndrome, right. So, and there's actually a relationship between Hashimoto's thyroiditis and sweet syndrome, which is also known as acute febrile neutrophilic dermatosis. So this is just sort of a internal medicine prelim or teaser to this case, but I thought it was pretty interesting. This is in the literature. You can find there's an association maybe just related to the fact that they're both immune dysregulation. She was started on thyroid replacement therapy and prednisone. Improved pretty rapidly, and she was discharged home with these meds, and also Lortab as needed because she was starting to have some sloughing, and the skin lesions were scabbing over and sloughing, and she was complaining of a lot of pain. So we discharged her home with these medications, and thought that we had a pretty one of the hospitalists was going to write this up as a pretty interesting case report, and we thought it was all tidy, and she was doing well. 5 days later, same patient presented to the ED again, this time with altered mental status. She was found really disoriented, wandering around outside the house, talking to herself, speaking incoherently, agitated when she arrived at the ER. Her husband, who accompanied her, said he thought she had been taking the prednisone and levothyroxine appropriately. Her prednisone dose was probably, I think it was 40 milligrams or 60 milligrams a day with a taper. It was supposed to be tapered. He wasn't sure, though. She had been complaining of a lot of pain and had taken Tylenol and Lortab multiple times in the interim for pain related to her rash, and she had no prior psychiatric history, no suicidality, there was no thinking that she intentionally overdosed, as far as we knew.
Well, I guess, was she febrile?
No, I'll go ahead and go to her exam. Maybe it'll help you a little. So she was afebrile. Pressure was relatively normal. Heart rate was up a little. She was very tachypnic, noted to be very tachypnic, but saturating 98% on a few liters of supplemental oxygen. She was oriented to person only and agitated. Her neck was supple. Her cranial nerve exam, including her pupillary exam, was normal. She was tachypnic. She was tachycardic, I'm sorry, with no murmurs. The chest was clear, but she was tachypnic. Her abdomen was soft, benign, basically a normal abdomen. She didn't have any signs of trauma, no external signs of infection. Any other exam you want?
No, that was already more than I would have done.
So don't forget about the rectal exam.
Oh, right, of course.
Gotta do the rectal exam. So the patient's urine drug screen was positive only for hydrocodone, which she had been prescribed. Her free T4, which was checked, was normal range. These are her other labs, and pertinent among those was a bicarb of 5, a creatinine of 1.7, an anion gap of 34. And this is her CBC. Her liver enzymes at this time were normal. Her lipase was elevated. And the labs, you can figure out.
Yeah, I guess serum osmoles.
Right. And then also, obviously, she's pretty profound metabolic acidosis. So this was her blood gas. Her pH was 7.11 with a PCO2 of 14 and her bicarb of 4 on the blood gas. Her acetaminophen level this is elevated, so it was up. But her ammonia was normal. And as I said before, AST and ALT were normal, or I think they were in the 50 to 60 range, maybe slightly above normal at this point. Her lactate was normal. Osms were, she did not have an osmolar gap, and her serum osms were pretty normal. And we tested for all the other mud piles things and could not find anything that would suggest what was going on, where was this metabolic acidosis coming from.
Mark?
Me, go ahead. Oh.
Yeah.
Well, I think there are things that could give you toxins that can give you acidosis in the absence of being detected in the osmolar gap, but I don't know what that would be in this case. What would they send her home on again? Prednisone and
prednisone, levothyroxine, and she had Lortab, and she was taking Tylenol at home. So she was admitted to the unit, obviously treated with bicarb drip, and then underwent dialysis that night for this unexplained metabolic acidosis. She did not require intubation. They empirically treated her with thiamine. They treated her with fomepizole. Okay, they weren't sure, is this methanol? But the osmolar gap was normal. But they went ahead and treated her with fomepizole. They gave her stress dose steroids. They gave her N-acetylcysteine because of this concern about the Tylenol level. Although it was not, I think on the nomogram for Tylenol, she didn't meet criteria to get treated with NAC, but they kind of treated her anyway. They gave her antibiotics just because it was this meningitis or something weird that was being confused by the metabolic acidosis. By the very next day, she was basically back to baseline.
Did you say salicylate level?
Oh, I'm sorry, that was also normal. Yeah, that was salicylates were.
Oh yeah, sorry.
The other thought would be delactate.
A delactate. That's a good thought, and that was something that was addressed at the time. I'm not sure that I don't think we did a delactate level, but we thought, does she have any rerouting of her innards that would lead to some kind of short gut or a area that's would grow bacteria, have bacterial overgrowth, and she didn't have that. She had no prior history of bypass or Roux-en-Y or anything like that. So the question was, what was the acid? And this is probably a little bit, even for internal medicine, and a little bit ridiculous, but one day a nephrologist actually who consulted on her asked the urine be sent for organic acid levels, and her 5-oxyproline in the urine was more than 200 times the upper limit of normal. So the final diagnosis in the case.
I don't even know what that is. What is that? That's supposed to give it away?
Oh, that's right. This is that glutathione synthetase.
It's glutathione synthetase. So she had this glutathione synthetase. This can be autosomal recessive disease, but there's also an acquired form. And again, this is so rare that it's really, there's no case reports of it being associated with Sweet syndrome and Hashimoto's thyroiditis. But the thinking is that when there's glutathione deficiency, either from Tylenol overdose or from sepsis, this can happen in critical illness as well. So somebody with very severe sepsis or something, when their glutathione is depleted, that this enzyme gets routed this way. So we have glutathione depletion, which negatively feeds back on this enzyme. So when this enzyme is basically unleashed, you get a lot more factors into this pathway, and you get a pyroglutamic acid overproduction. So you get excess pyroglutamic acid, and then this is excreted in the urine as 5-oxyproline. So that's how we detected, but the acid in her blood was actually pyroglutamic acid.
What kind of fellow did you say you were?
So, no relationship to COPD, by the way, Mark. There's no association here. But did anybody else? How many folks have seen a case of glutathione synthetase deficiency in the community, or anywhere in your practice? Dr. Johnson, you had a comment?
I was just thinking that the pressure's off. Now that I know that all the cases are going to be single case reports, if I don't get it right, I'm okay.
Well, the next one, maybe not so much.
And I had actually not heard of the patient with the ochroconus, but I didn't let on because I knew it was going to be bad. So anyway, yeah. But it's very interesting.
Okay, so I mean, I should say that none of us, including me, we're unaware of these cases. So we're seeing it for the first time. John, you're going to move on to the next case?
Sure, I have one more.
Okay. The last case of the day.
And
there is some pulmonary content here. I mean, there's some lung disease. And so
there's a lung biopsy.
This is pulmonary and critical care update, by
There's
the
a
way.
lung biopsy in this patient.
All right.
So this is the case of severe obstruction in a young female non-smoker. This was the case that Angel gave me, so I didn't think of a clever name for it. I'm sorry. So this is the summary of the patient. Again, a patient with renal disease. This lady's 23, history of end-stage renal disease. She had hemolytic uremic syndrome as a child. She was hospitalized for pneumonia and a pulmonary embolism approximately 8 months prior to when she was seen by us at UAB. And her history when she presented to UAB was that she had approximately, 2 months after her prior illness, she developed dry cough, wheezing, and dyspnea on exertion. And review systems, her wheezing was worse and cough was worse when recumbent. She had increasing dyspnea with exercise, and then really no other constitutional symptoms in terms of fever. Her weight was stable, so no other major symptoms going on at that time. Medical history, again, she had ESRD from hemolytic uremic syndrome, had been on dialysis, and then anemia of chronic disease, ovarian cyst, and had unfortunately had a couple of, or actually 3 different kidney transplants, and had explants related to graft failure, or nephrectomies related to graft failure and retransplant.
Moderator does this one.
Family history, again, she had lung cancer in her paternal grandfather. Mother and father had hypertension. She was single, lived with her mom, denied ever smoking cigarettes, no alcohol, no drugs, really no exposures to any respiratory irritants that she could recall, or occupational exposures, or recreational use of anything that she told us about. These were her allergies, amphotericin B, contrast dye, and Dilaudid, which all caused a rash. And these are her meds at the time of presentation, notably Advair, Duaneb. She was on Coumadin still for the prior PTE, some medicines, Ventolin as well, and then some EPO for her anemia, a few other things. This was her physical exam. Tachycardic, a little bit tachypnic, a little bit hypotensive, but again, she's 23 years old, so this was not really a huge concern. She's mentating normally, saturating at this point in time 97% on room air. Her peak flow was low, and her BMI was in just within normal range. Pretty much pretty normal exam, no acute distress. Her HENT exam was all fairly normal. Neck was supple. Her chest was documented as being clear to auscultation bilaterally, and she didn't have labored breathing. So really not a very contributory exam. And then so they went ahead, because she was in the pulmonary clinic, she got PFTs, and these were her PFTs, which, I'm sorry, should have made Dr. Thannickal interpret these. But anyway, so this is her PFTs at this time. So with a basically normal, what we think is kind of a normal lady with a subacute onset of dry cough, wheeze, dyspnea on exertion, and these PFTs, any thoughts about the...
Dr. Cooper, what do you think about these PFTs?
She's obstructed and restricted, and she has a diffusion impairment.
Okay.
So she was diagnosed with asthma. You know, they said maybe this is just asthma, a little atypical, but you know, is this something weird going on? So they decided, you know, she's already on decent, what you would say would be decent asthma therapy. She's on inhaled corticosteroid, and she's on rescue inhaler and Duneb. So they said, you know, we're going to continue these meds, and we'll see her. We'll get a CT scan on her and see her back in a couple of months. So interval history, so the CT was done, and based on the findings of that CT, they brought her into the clinic just to provide a sputum specimen, which was positive for Pseudomonas and Staph aureus. She was treated with a fluoroquinolone, which I'm not trying to propose that Staph aureus be treated with fluoroquinolones, but she did improve a little bit. She said she got a little bit better with the fluoroquinolone, although she still had some cough with sputum. And got worse again right after the antibiotics were completed. So this is I'll go ahead and go to her x-rays.
Yeah, let me ask Dr. Anthony to comment on those organisms cultured from the sputum in this clinical setting.
So in a young person with sputum positive for Pseudomonas and Staph, it's kind of unusual with just plain asthma. I would worry that she has some underlying bronchiectasis. You said that her CT scan prompted her being brought back into to get more testing done. In these kind of patients, in a young patient with probable bronchiectasis, you want to think of course, cystic fibrosis and other reasons for her having bronchiectasis.
So this is her x-ray, again, CT scan, and they noted some kind of linear opacities here.
Right, so she does have, these sort of patchy areas of fluffy infiltrates. In some places, they've coalesced together to form nodules. And she may also have some signs of bronchiectasis with some tram lining and increased bronchovascular markings.
So these are just the reports. The poorly defined bilateral nodular and granulous opacities, more pronounced in the right, middle, and lower lobe. They didn't notice not a lot of bronchiectasis, air trapping, or pleural disease. So they brought her in. She was admitted for an inpatient bronchoscopy. This is not the patient I saw. I'm not sure why they admitted her, but she had an inpatient bronchoscopy. They stopped the Advair, and when she was admitted that time, again, a non-remarkable exam, except at that point in time, she had diffuse expiratory wheezing. These are her labs on the admission for that bronchoscopy, and again, she was on Coumadin, but otherwise, and this obviously is related to her. She had failed renal transplant. So on October 2nd, her transbronchial biopsies resulted in a staph epidermidis and Achromobacter, and her BAL was reported to be negative the cytology was negative for malignancy, fungi and pneumocystis. So does that kind of change anything about?
I think, staph epidermis is sort of unusual, but the alkalginese is common enough in patients with bronchiectasis or in patients with cystic fibrosis. So at this point, I would be considering sending off other tests, or even for starting with a simple sweat test and doing other tests for why she has possible infection with these organisms.
Right. So that was done, and everything that they did was normal. She had a normal sweat testing, and so the transbronchial biopsies the pathology returned 3 days later, and this is kind of when things got interesting. As I said, she had of alveolar tissue, which is basically unremarkable, but they did notice that she has these aggregates of primitive appearing small blue cells adjacent to ciliated respiratory epithelium, and they have a possible neuroendocrine appearance. The wedge biopsy that she had was pretty, I think, pretty non-contributory to the whole thing. So based on that, let's see, I have some pictures here. So again, the small blue cells here, closer, and then I think this is just to show these areas here, and then here. So any thoughts about that?
So may I just ask our expert panel, and I'm just actually going to open it up as well to the audience. If you raise your hand, if you have some comments on this, if you have any additional thoughts, I'll start with the panel first. Anybody want to comment on this? I think those blue cells look like lymphocytes in a patient with asthma. Could this be lymphocytic bronchitis? Any other? Is Dr. Jim Bonner here? He may have some thoughts on that. Anybody else have any thoughts? All right. I'm not sure what this is, John. Keep going.
So this was the differential diagnosis was, again, asthma. Is this related to some kind of early COPD, GERD? And then this entity, diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, which is what her final diagnosis was based on her pathology.
So those weren't lymphocytes then?
No, they were actually neuroendocrine cells. And they were, it's rare. There's been some cases described, though, generalized proliferation of these single cells and small nodules or linear proliferations of these pulmonary neuroendocrine cells, and restricted again to the basement membrane. So the kind of this pattern that you can see, and they're normally in infant lungs, but in adult lungs this is an abnormality, and it's considered to be a precursor for the pulmonary carcinoid tumors when they extend beyond the basement membrane. Again, this patient was typical, except that she was a little bit young. I'm not sure how that ties into her immunosuppressed status and her prior kidney transplants. So again, female predominance, and can present with patients with progressive cough and dyspnea with obstructive PFTs. And I think the thinking on the spirometry, why it's obstructive, is that there's bulging of the airways because of the neuroendocrine cell growth underneath, and there can actually be invasion into the airways, and at which point they get kind of a obliteration of the airways. They get small airways disease followed basically by fibrosis related to these cells growing eventually into the airway. Very little known regarding management, but this patient, based on case reports and what literature we could find, she was treated with corticosteroids, oral corticosteroids. She got better and discharged home after her INR was therapeutic and was to follow her with her outpatient pulmonologist. And I think that's it. And I always acknowledge the internet because that's where everybody gets all their information. And Angel Brown, who gave me this case. I don't know if anybody has any comments about this or anything else.
Well, John, that's a great bunch of cases, 3 really unusual cases. And I want to thank everybody for participating. I want to thank Dr. Cooper for organizing this pulmonary update, and specifically the clinical portion of it. Dr. DeShane organized the clinical and translational component yesterday. And I really want to thank all of you for participating. I just want to ask you all in the audience to please continue to support this. If we were going to continue this year in and year out, if you're going to do it every year. Now, again, CMEs are a growing a requirement. So again, you will need those. Everybody will need those in the future. So we need to continue this. I'm not sure if you're going to have this here at the same venue next year. We want to continue it yearly. It's a good way to connect with you, with our fellows, and some of our faculty who sometimes move on to practice in the community. And again, Rob Garver is an example of that. Again, thanks everyone for participating. Let's give the expert panel a round of applause for their participation and discussion. Thank you all for coming. Appreciate it.